So good evening all. I welcome everyone to the IRIA Kerala PG case presentation series in association with JournoMed. And towards this, I welcome President Kerala IRIA, Secretary Kerala IRIA, and Program Coordinator Dr. Ramesh Shenai. And also I welcome Dr. Anish, today's coordinator, and Dr. Nawab, who is the faculty of today's program. I once again welcome everybody. And now over to Dr. Anish for the introduction of the faculty.
Yeah, thank you, sir. I'm here to introduce the faculty of today, Dr. Nawab. He is currently working as assistant professor in Malabar Medical College. I'm also working in the same medical college. He has done his MD from JIPMER, Pondicherry, and after that he has joined MMC as a senior resident and currently as an AP. He has interest in academic activities and he has few publications and all. First time he is associating with IRIA Kerala academic program this year. I welcome Dr. Nawab once again. I also once again welcome the PGs for today's program, Dr. Narmeen and Dr. Arya from Calicut Medical College. I think Dr. Nawab, you can start the session. Over to Nawab.
Good evening to all. I would like to thank IRIA, JournoMed, Dr. Anish sir and Dr. Gomati madam for giving me this opportunity. Today, I have two short cases and few spotters for each PG. We are directly starting to the case. Hello, Dr. Narmi. Hello. Hello, PG. Hello.
Yes, sir.
Okay.
Sir, I'm here.
Can you see the images?
Yes, sir. Yes, sir.
Oh. So tell me, what is the finding? Where is the lesion located? And what are your differential diagnosis?
Sir, in the ultrasound image, I saw a very well-defined hypoechoic lesion, oval in shape, and it is oriented parallel to the probe.
Okay.
In the CT sections.
I will give you one clue. Patient presented with palpable cheek swelling on left side.
Sir, near the parotid gland,
yeah.
Deep to the parotid gland, I see a soft tissue density area.
So the location is in left parotid space, right?
Which has a well-defined pattern. Yes, sir.
Okay.
Deep lobe of parotid. Deep lobe of parotid. And it has a well-defined fat plane with adjacent mandible, the carotid vessels, and the prevertebral muscles, paravertebral muscles.
Okay.
So, and in the ultrasound also, I think the lesion is within the parotid gland. So,
okay.
By the morphology of the lesion, I think it's a benign, benign lesion of parotid, likely a pleomorphic adenoma.
Yeah. So in contrast section, axial section next show a well-defined microlobulated soft tissue density lesion with an enhancement. Okay.
Yes, sir.
So in ultrasound, you told like it is a well-defined hypoechoic lesion, and one point you can see some posterior acoustic enhancement in this lesion. Can you see?
Yes, sir. Yes. Yes, sir.
So the location of the lesion is in left parotid space, right?
Yes, sir.
So your diagnosis is pleomorphic adenoma.
Benign tumor of parotid or an enlarged intraparotid lymph node.
Okay, okay. So I will give you this MRI pictures of this patient. Can you see it?
Yes, sir.
So
it appears.
What is the first sequence?
First sequence, the T2 fat suppressed.
Yes. What you are seeing?
It's a very bright lesion on the hyper.
Okay. Well defined.
Hypointense in T1, and it shows it's well defined.
Enhancement.
It's well enhancing lesion.
Okay. So your diagnosis is pleomorphic adenoma, right?
Yes, sir.
Okay. So the key imaging features of this patient is circumscribed T2 bright parotid lesion and showing some contrast, heterogeneous contrast enhancement. In this lesion, there is no features of hemorrhage or calcification. Okay. So
Yes, sir.
this is the most common benign parotid lesion, right?
Yes, sir.
What are the other lesions in parotid, benign lesions?
Lymphoepithelial cyst,
Okay.
simple cyst,
Okay.
benign intraparotid lymph nodes.
Okay. So you told what is the commonest lesion in the parapharyngeal space, benign lesion in the parapharyngeal space?
In the parapharyngeal space, it should be a lesion from the deep lobe of parotid invading parapharyngeal space.
Okay. Then also the lesion is pleomorphic adenoma. Okay. That is the
Yes.
commonest lesion in the parapharyngeal. So what all the area you can see the pleomorphic adenoma other than parotid?
Then I can see that it also in the other salivary glands,
Yes. Then
ectopic salivary glands.
then other than salivary gland,
and salivary glands.
what about lacrimal gland?
Yes, sir. Yes, that
You can see in the submandibular gland. I already told this is the commonest tumor in the parapharyngeal space. Right. Then you can also
Yes, sir.
see in the soft palate. The last image you can see the lacrimal gland lesion. These all are the other locations of pleomorphic adenoma. Okay.
Okay, sir.
So we are moving to the differential diagnosis. We know that parotid space that can be multiple lesion. You already told about cystic lesion, benign epithelial cyst, benign tumors, and all. So we are moving to next case. What are you seeing in this case? This is actually a companion case, almost a similar appearance. But what is your diagnosis? What you are seeing? You can describe the lesion if you have some doubt. First is
the lesion also appears to be from the parotid gland.
Yeah.
There is in
T2
it is heterogeneously hyperintense.
Okay.
With few internal septations. In T1, it is T1 also appears heterogeneous with some
section,
hypointense area
that
and some
image B is
area.
This image B is T2 weighted. You are seeing a well-defined bright lesion, almost similar to that of the parotid gland, right?
Yes, sir.
Then on contrast, you are seeing a heterogeneous lesion with a few cystic or unenhancing area, right?
Yes, sir.
So what you are seeing in the last image, I marked one arrow there. Can you see that?
Yes, sir.
So what is that? What is that sign called? What is your diagnosis? Okay, I will give you. Okay, tell me.
It has an extension.
Yeah. Okay, I will give you some clues. What are the other lesions in parotid? Like we have some vessel, we have some nerves and all there, right?
Yes,
what
sir.
are the other content of parotid?
So there is branches of external carotid artery. There is retromandibular vein.
Okay,
nerve. Then there is facial nerve.
Okay.
So it could be facial nerve.
Can you see that lesion is extending to the stylomastoid foramen superiorly?
Yes. Yes.
Okay.
Sir, yes.
So what is your diagnosis now?
It's from the facial nerve.
Oh, so that is facial nerve. Schwannoma or neuroma. That is extending to the
parotid.
Superior stylomastoid
foramen.
This called string sign. Okay, this extension. Okay. I will ask another question. What is the commonest parotid tumor with perineural or perivascular spread?
Adenoid cystic carcinoma.
Okay. So what is the commonest malignant tumors of the parotid gland?
Adenoid cystic carcinoma, acinic cell carcinoma.
Commonest
adenocarcinoma.
No. It is a mucoepidermoid carcinoma. Okay. Mucoepidermoid. Okay.
Yes,
so initially, image wise, it is that is also we have low grade and high grade. Okay, low grade lesion, it is very difficult to differentiate from the pleomorphic adenoma. Okay, high grade lesion, there may be some features of like ill-defined lesion, deep extension and all, but also that is image wise we have not much details. Okay, next I am going to. Okay, what are the other bilateral parotid gland lesions?
Bilateral Orthin's tumor.
Okay.
Then Sjogren syndrome can have bilateral involvement.
Okay.
Then other infiltrative conditions like sarcoidosis.
Okay. Then we have some, you already mentioned there is some nodes and all. So what is other possibilities?
Lymphoma. No.
Very good. Then other is some nodal metastasis. Okay. So
Yes.
we'll move to next case. You see, what are you see? This is a smoker with a bilateral cheek swelling. What are you seeing?
It's bilateral enhancing lesions within the parotid gland.
Yes, with some cystic area. Even the CT, you can see some hypo-enhancing area, right?
Yes, sir.
What are you seeing in ultrasound images?
Ultrasound, hypoechoic lesion, roughly oval in shape, with some cystic areas and
We
good
can tell
internal
it is
vascularity.
predominantly solid cystic lesion with a solid component showing some vascularity, right?
Yes.
So what is your diagnosis? You already told about that.
Orthin's tumor.
Okay. That is bilateral, multifocal. How much percentage it can be? It is almost 10 to 20% can be bilateral. It is not always bilateral. Sometimes it can be unilateral also. So sometimes cystic variety of the pleomorphic adenoma is a differential, right?
Okay.
Next case, what you are seeing is also a companion case. We are seeing what are the okay
in the axial sections of CT thorax in the contrast after contrast. I see a soft tissue density, well circumscribed soft tissue density in right paratracheal location, right upper paratracheal location.
Okay.
And it has maintained fat plane with the arch of aorta.
Okay. So that can be the paratracheal nodes. Okay. So what are you seeing in the next images like CECT, neck, what you are seeing? You are seeing like enlarged parotid with fuel focal lesion. Okay. Another image I am giving. You can see that like axial contrast section.
Yes, sir.
What are you seeing that you can see bilateral? Can you see this bilateral lacrimal gland enlargement?
Yes, yes,
so this is one of case you already mentioned. This is case of
Sjogren syndrome.
Sjogren's or sarcoidosis. Sarcoidosis. Okay. Next case. This is same patient. You can see that bilateral parotid gland show multiple lesions, right? And you can also see some nodes in the cervical and mediastinal and axillary region. So this is a case of very good. This is a case of lymphoma. Okay.
Okay, sir.
So next cases. This is a HIV positive patient with bilateral cheek swelling. What is the HIV manifestation?
HIV cellopathy.
Then you already mentioned that for differential. Benign epithelial, lymphoepithelial lesions of the parotid. Okay. So what are you seeing in this image? First image, what you are seeing?
Bulky, bilateral parotid is bulky.
Glands, and also you can tiny hyperindent foci within. Okay. This is the features of lymphoepithelial cyst. You can also see the multiple cervical lymph node, right?
Yes, sir.
Okay, so this is benign lymphoepithelial lesions of this is one of the HIV manifestation. Okay.
Yes, sir.
Next case, swelling both cheeks with dry mouth. So clinically also you can tell what is that. So what are you seeing? What is that appearance in? What first one is T1 weighted image, and you are seeing T2 weighted image. T1 weighted image, what you are seeing, both you can see that fatty infiltration of the parotid gland, you can see, right?
Yes.
And T1 you can see some granular appearance.
Yes.
Okay.
Yes,
T2 weighted, you can see multiple, like you already told, multiple tiny hyperindent foci in both lobe, right?
Yes.
What is that actually?
So lymphoid aggregates.
No, actually that is a terminal dilated branch ducts. Okay.
Okay,
So
sir.
this is a case of Sjogren's syndrome. Okay.
Okay.
Next case is actually what you are seeing.
After dental procedure.
After dental procedure, what you are seeing?
This is abscess.
Can you see some air pockets inside
Yes,
the
sir.
parotid and it is extending along the masseter, anterior masseter?
Yes, along the
Okay.
stents and duct.
Oh, so what is that? If you are seeing some air in the orbit, what you tell?
Emphysema, orbital emphysema.
Other case, pneumo-orbit you will tell, right? So this is a case of pneumoparotid, right? This is also one of the differential for bilateral parotid gland swelling. Okay.
Okay, sir.
So the last case, actually patient presented with a bilateral cheek swelling, and but both on ultrasound, both parotid gland was normal. Only few lymph nodes, benign lymph nodes are seen. What are you seeing in this case?
Bilateral masseter appears hypertrophy.
Yeah. So that is the pseudo tumor bilateral masseter hypertrophy. Okay.
Okay, sir.
So next we will go to the next case, right?
Okay, sir.
Before that, I just want to tell the differentials of parotid. We had seen like masseter hypertrophy, right?
Okay, sir.
Then Sjogren's syndrome, then benign epithelial cysts, benign tumors, everything we covered. Okay.
Okay, sir.
So we will move to the next case. Can you see that?
Yes, sir. Yes. Next.
So tell me where is the location of the lesion first?
The lesion is located within the carotid space.
For spot test, now you have to tell which is right or left. That is very important.
Okay. Right carotid space.
Okay, right carotid space. Okay.
And so, it is causing splaying of branches of carotid vessels.
What is that arrowhead anteriorly? What is that arrow posteriorly?
The ICA is pushed posteriorly and ECA is pushed anteriorly.
Okay. So you are seeing one lesion in the carotid space. This is a contrast CT, right? What about this enhancement?
It's a well enhancing lesion in the arterial face.
So okay. So what is your diagnosis?
My first diagnosis is a paraganglioma, carotid body tumor.
Okay. What are other paraganglioma? In the neck region?
Glomus vagal, glomus jugular, glomus tympanicum.
Then how you differentiate why it is not glomus vagal?
Glomus vagal usually is located posteriorly, and it pushes both ICA and ECA anteriorly.
Okay, very good. So what are the carotid space contents? We have carotid artery, internal jugular vein, vagus nerve. So these all lesions can come as a differential. But this is almost a typical diagnosis like what is carotid body tumor. So I am giving some MRI features of this lesion.
Yes,
first one is T1 weighted, T2 weighted image, then is T1 weighted, then is the contrast. Okay. So tell me what are you seeing in the T2 weighted image?
T2 weighted images, the lesion appears hyperintense with multiple intra-lesional flow voids.
Oh, very good.
T1 is its iso-intense to muscle. And in contrast, it has a brilliant contrast enhancement.
Okay. Then at coronal section, section, you can see that
it's causing splaying.
What is that sign called?
IC and ECA called Liaison.
Okay, what are the signs explained in the paraganglioma other than this Liaison paraganglioma? I do not mean carotid body tumor. What is this sign? You can see some T1 weighted image, right?
Yes, sir. So this is the splaying of vessels.
That is okay on right side.
And then you can salt and pepper sign.
Oh, what do you mean by salt and pepper sign?
There is areas of hyperintensity and mixed with areas of flow voids.
Yeah. Why there is hyperintensity? What is the reason for hyperintensity?
Hyperintensity is not sure.
Subacute hemorrhage. Okay. Hypointensity.
It's a flow voids.
Yeah. Very good. Okay. So this is an ultrasound image. You can clearly see that the external carotid artery is placed anteriorly, and this is other signs of Liaison. Okay. So imaging characteristic you already told is a T2
Yes.
hyperintense with the flow wide. This salt and pepper appearance is classically described in T1 weighted image. Sometimes we will see in the T2, but it's classically described in the T2 weighted image. Okay. So this patient presented with unilateral tinnitus. What is your diagnosis? Where is the location of the lesion?
There is a soft tissue density lesion within the tympanic cavity.
What is that location, that arrowed area? We will tell that we will see some soft tissue density lesion at this area and is projecting to
Hypotympanic.
no, that is cochlear promontory. That level is called. Okay, that is typical of which nerve is causing this?
Ninth nerve.
What is branch of? It's the inferior tympanic nerve. It's called the Jacobson nerve. Okay, branch of glotopharyngeal nerve. Very good. So about this case, you already told. There is no splaying, but displacement of the both ICA and the ECA anteriorly and the IJV posteriorly. So what is your diagnosis?
This could be a schwannoma.
No, that same appearance.
Glomusvagal.
Okay, very good. So I'm going to last case. What do you see in the axial section? CT
in the CT sections, there is a widening of the jugular foramen with the permeative destruction of the bone.
Very good. Okay.
And in MR images, there is soft tissue, intermediate T2 intermediate soft tissue within the jugular foramen.
Same salt and pepper appearance.
Yes,
so what is that?
Glomus jugular.
Okay, very good. So next we are moving to the rapid round cases. Okay. So can you see this image, Nermi?
Yes, sir.
This 63-year-old female patient presented with a progressive hearing loss, otorrhea, and oral fullness for last 2 years. What do you see?
So there's a CP angle lesion which is extending into the internal acoustic meatus.
Is it a CP angle lesion or Petrus action? It is located in the
Petrus apex. Yes.
Okay. Okay. What do you see? What is the appearance in T1, T2, and diffusion restriction? I already otorrhea patient. This is a case of the chronic otitis media, some unsafe variety. So what will be your diagnosis?
Cholesteatoma.
Yeah, very good. Very good. Which sequence we are usually using to differentiate from cholesterol granuloma and cholesteatoma in
diffusion
restriction? So this is diffusion bright, right?
Yes, sir.
Oh, what will be the difference with the cholesterol granuloma? What will be the appearance?
Cholesterol granuloma will be T1 hyper.
Yeah, very good. Okay, okay. So this diffusion. Oh, that is the. So this is Petrus cholesteatoma. Okay. So next case. This is very simple case. I already marked. Where is the lesion? What is diagnosis? What is etiology?
So cavernous lesion.
Yes, cavernous sinus. You can see some filling defect also in contrast. So cavernous sinus thrombosis. Okay. The etiology, you can see sphenoid sinus also. Sphenoid sinusitis. Okay.
Okay, sir.
So next case, this patient presented with fever with swelling. You can see multiple some abscess-like lesion. Which all spaces is involved in this?
Here, submandibular area extended.
And what is this space?
Parapharyngeal space.
No, this is tongue, right? So this area is sublingual space. It is extending to the submandibular space and the submucosal layer. So this is actually Ludwig angina. Okay.
Yes.
What is this case? Patient presented with progressive vision loss. What are you seeing?
Optic nerve meningioma.
Very good. Okay. Tram tract calcification. Okay. What is this? Bilateral patient presented with a bilateral mixed hearing loss.
There is a destruction of pages.
Yeah, that means it is only destruction or sclerosis. Both are there, right?
Both are,
sclerotic
yes.
and lytic. Then why there is some this
cochlear region is spared.
You can see some demineralization around otic capsule also. You can see that this area and all. This is not much.
Okay.
Okay, so this is a case of Paget disease. What are the differential? If there is not much changes in the temporal lobe, you are seeing only demineralization in the aortic capsule and or pericochlear region. What is your diagnosis?
Osteotis deformans.
No, otosclerosis, right? Otosclerosis or spongiosis. Okay. So, this is a very simple case. Tell me what is your diagnosis? Is there any suspicious features or something?
Cyst with the malignant transformation.
Why you are telling malignant transformation?
There is a papillary growth with the internal vascularity.
Okay. But that can be due to also prior infection. Then what are other pathognomic? Can you see in the CT some microcalcification also?
Yes, microscope.
Tiny micro. That is more suspicion that this vascular lesion, right? For the what are the commonest malignancy arising from this?
Papillary carcinoma.
Papillary carcinoma. Okay.
Yes, sir.
Hello, Nermi. Next case.
Yes, sir. Yes.
Young woman with a headache.
Young woman with headache. So it's a clivus-based lesion.
Okay. On sphenoid bone, what you are seeing some lesion, right?
Yes,
The
sir.
density is all coming around fat density lesion. Okay. The even weighted image, it is bright. Okay. So contrast, not much enhancement. There is no expansion of the bone to tell it is cholesterol granuloma or something. So what is this? It's a do not touch lesion. It's one of the typical spot tests.
Physalifora.
No. This is actually benign fatty lesion of the sphenoid, also called arrested pneumatization. Okay, this is a classic don't touch lesion. How to differentiate from the in cholestoma, there is some expansion lytic area and all. It won't be there. Okay, there is some sclerotic area with some low internal fat density. Last case, one more case. See this case. This patient presented with. Okay, anterior tongue, you are seeing some cystic lesion. Okay.
Okay, sir.
That is not showing any diffusion restriction. So what are your differential?
Anterior tongue. Ectopic thyroid.
Infant.
Ectopic thyroid.
There's a commonest location is anterior or posterior?
Posterior. Lymphangioma.
Okay, then. This is actually forget duplication cyst. Okay, one of the differential is epidermoid cyst. That is why we put that ADC image. What is the what ADC will be? Epidermoid.
Low in epidermoid. Low in epidermoid.
Okay, very good. So
right side hearing loss.
This is actually I already mentioned. This image some demineralization is there. So I am just skipping that list. Okay. So pain swelling in right orbit, what you are seeing?
There is a subperiosteal abscess, intracondylar extension, cellulitis, orbital cellulitis.
Preseptal and postseptal. Okay, very good. This is the case of orbital cellulitis. Okay. This child with unilateral sensorineural hearing loss. This is such an oblique sagittal view of internal auditory canal.
Right, internal. But left.
How many nerves? How many nerves will be there? So what are the nerves? Superiorly?
4.
Anterosuperiorly?
Superior and inferior vestibular. Vestibular.
That is posterior.
Both superior and inferior division.
Okay.
Then for 7th nerve and 8th nerve.
So which nerve is absent?
Nerve is missing.
Anteroinferior. So that this is a congenital anomaly with the epiphytic cochlear nerve. You can see this, right? Anteriorly you are seeing, anterosuperiorly you are seeing facial nerve. Okay. Well, in the left side you can see that cochlear nerve. This nerve is absent here, right?
Yes, sir.
Oh, this is the case of deficiency of the cochlear nerve. Okay. So we are moving to next person, I think. Or you are continuing.
So, thanks.
Thank you, Narmin. You did very well.
Next person will take.
Dr. Arya, can you hear me?
Yes, sir.
So, what do you see in this case?
There's widening of the prevertebral space. In
Okay.
the upper region.
What is your measurement to tell it is widening? C2 level and C6 level? What is the cutoff? That is around 7 mm in superiorly C2 level, in 21 mm in the inferiorly. Okay, so there is, can you hear me? Hello, Arya? Hello, Arya? Hello? Hello, Arya?
I think there is some network issues.
Okay.
She should either join back or she should correct her, headphones.
Nermin, are you okay to continue?
Yes, I will continue.
Okay. So she told there is, okay. So what is your diagnosis?
So my diagnosis of retropharyngeal abscess.
Hmm.
Here I can see that there is an peripherally enhancing collection in the retropharyngeal space, which is also extending to the prevertebral space.
Okay, then?
And there is in the coronal sections, there is some
subluxation of the axial joint with some torticollis. Even you can see it in the axial section, right? So what is the diagnosis? It's a retropharyngeal abscess with a Grisel syndrome, right? Okay. This associated atlantoaxial subluxation also you can see, right? Here with the torticollis. Okay.
Oh, yes, sir. Yes, sir.
So
okay, sir.
What is this case? It's a companion case. What do you see in this? See, this case also in T2 weighted, you can see some fluid, right, in the retropharyngeal space. Can you see that minimal fluid?
Yes. But
then,
it's not widened.
Yeah, widened? Not much. So,
widened.
So, what are the causes of retropharyngeal space widening? You can see a retropharyngeal abscess, like our last case. Then you can see it's a calcific tendinitis. There won't be much abscess and minimal fluid or edema will be there. Okay, that is one case of the calcific tendinitis. Even in SVC thrombosis also we can see this retropharyngeal space. Can you see this case? This is you can see some calcific. Can you see that C2 level, right? This is actually calcification of the longus collis tendon. This is actually calcific tendinitis of the longus collis tendon. Okay, so you are seeing some amorphous calcification typically on the superior fibers. That is on C1, C2 level you will see. Then also you will see some edema in the retropharyngeal space. Okay, so that is one of the differentials for longus collis. So how to differentiate? We have no peripheral enhancing abscess in this to tell this is what retropharyngeal abscess. Also, we won't see much lymph nodes. Usually in retropharyngeal abscess, we will see some necrotic lymph nodes also. Okay, so next case you see, what is the density of that lesion?
That's fat density.
So that is retropharyngeal.
That is fat density.
Lipoma. Okay.
Lipoma.
Okay. Okay. Retropharyngeal. This is the case I told. Na? Superior venous cava syndrome with the retropharyngeal edema. Can you see that multiple prominent azygous vein and multiple collateral veins? And also you can see some edema in the retropharyngeal space. Can you see that?
Okay,
this is also one of the differential. Okay.
Okay.
Okay, so what are the, in this page you can see some complication also, that rupture of the
Structuring into
retropharyngeal
the
space
pharynx.
to the access to the pharynx also. You can see that pus is coming, right? So what are the complications
Yes, sir.
of retropharyngeal abscess?
It can the retropharyngeal space will extend in the retroesophageal area and also can reach up to the anterior mediastinum. It can cause mediastinitis. Posteriorly, it can involve the prevertebral space, and anteriorly, it's the main complication is it can extend into the anterior mediastinum.
Okay, okay. So next case we will go. 14-year boy presented with epistasis. So what you are seeing in this view?
In this view, in the maxillary sinus
I
on the
just
right
arrow
side
mark.
appears opacified. Maxillary sinus on the right side appears opacified.
Okay, so what is this? Can you see this lateral view? It is not much clear. Can you see that this lesion is maxillary or retromaxillary on lateral view?
Retromaxillary causing anterior bowing of the posterior wall.
So what is that sign called? Is it in a CT sign or X-ray sign? Okay, so can you see this lesion?
Yes, sir.
Okay, this lesion.
So there is a lesion behind the right maxilla, which is extending both into the nasal cavity, the pterygopalatine fossa, and into the infratemporal compartment.
So what?
This is a case of with a widening of that area.
Okay, so what is your diagnosis?
It's an nasopharyngeal, juvenile nasopharyngeal angiofibroma.
Okay, where is that location of origin of this lesion? Classically described in?
Sphenopalatine foramen, sir.
Very good, very good.
Sphenopalatine foramen.
Very. So this is that Ullmann-Miller sign, right? That bowing of the posterior wall you can clearly see, right? So what about this enhancement? What is the enhancement of this lesion usually? Hello, Narmi?
Yes, sir.
You can see intense heterogeneous enhancement.
Highly vascular lesion with brilliant.
Okay, okay. So MRI, what you are seeing this lesion? Similar to that of,
within the lesion.
yeah, yeah. That means it is a hypervascular lesion, right?
Yes, sir.
So what is this image?
This is a DSA image after cannulating the ECA.
Okay, so what you are seeing in that image?
External carotid artery.
Oh, and which is the commonest blood to the from the maxillary artery? Okay, maxillary artery is the commonest cause. Okay, so we can do embolization. So we will go to the rapid round now, right?
Okay, sir.
So what is your diagnosis? What you are seeing? It's a T2 weighted image you are seeing.
So it's a. There's a hyperintense.
What is that location?
Intensity lesion.
What is that location?
Extending from the sublingual compartment to the parotid. It's a plunging granule. It's just
extending to the submandibular compartment. Sublingual space. Oh, this is, you are right initially. It is a sublingual space cystic lesion extended submandibular space. So what is that?
It's a plunging granula.
Okay. What is that muscle which is separating these two compartments? Floor of mouth.
Mylohyoid.
Yeah, very good. So this is a yes, yes. If it is simple ranula, means it's only confined to the sublingual space. Okay. If it is PAC mylohyoid and extending to the submandibular space, we will call it as a. Okay. What is this case? Elderly patient with vague vision loss.
Vision loss. There is a T1 bright lesion in the right lateral aspect of the globe. There is a fallen ADC. An ultrasound image is also given. I'm thinking of a melanoma.
Oh, okay. Why it is melanoma?
It's hyper in T1.
Okay. Very good. Okay, very good. Choroidal melanoma. Then adult with the jaw swelling, what you are seeing in the bony lesion? You can see some bony lesion.
Bony lesion, yes, in the mandible causing expansion of the cortex. However, the cortex appears very thinned out. Or is it amyloblastoma?
Yeah, very good. So this is a locally aggressive benign tumor, right? There is thinning, most commonly in the mandible.
Yes,
It can be unilocular or multilocular.
Hmm.
Sometimes the closest differential is odontogenic keratosis. Okay.
Okay, sir.
So what
Yes,
is
sir.
this? What is this lesion?
It's a mucosal of the mucosal.
Why
From the
mucosal?
left. It's hyper in
Little-
T1 with peripheral contrast enhancement.
So
So,
what is the lesion? This is can it be a polypoid lesion arising from and it is extending to the nasal cavity? So what is that lesion? And it is extending to
Antroconal
cornea.
polyp.
Yeah, the MRI image is given. That is why you are confused. So how you differentiate from this inverted papilloma and all?
Inverted papilloma, there's a typical appearance which is called a cerebriform convolutional pattern,
Okay.
and it is homogeneously enhancing rather than peripheral enhancement.
Okay. Very good.
And the lesion is
What are the other that one case is coming? We will discuss that time. Okay. So you are seeing some AC polyp, right? So
Okay, sir.
polypoid mass originating from the maxillary antrum, and it is extending to the cornea posteriorly. Fluids. This only we will see only the peripheral enhancement, right? Okay. The next case, roofer working without high protection. What you are seeing?
for working the type protection. So that's a cataractus lens.
Hello?
Fractured lens.
Fracture?
The lens on the right side appears abnormal.
What is that abnormal? What you are seeing?
Perforated lens.
Not perforated. It is little hypodense and thinned out, right? It is a case of cataract actually, because it is also called a lens edema.
Okay.
So imaging hypoattenuating in CT appearance of the lens. It's also called acute lens edema. So it can be associated with the other injury also. Okay. The etiology is due to there is disruption of the lens capsule, allow fluid enter to the lens, resulting in hyperattenuation on the CT. Right. Okay. So diabetes patient with the facial swelling. What are you seeing?
Okay. There is sir, IRIA is online now. If you want, he can continue from.
IRIA, can you hear me?
Yes, sir.
So what you're seeing in what are the CCT? What you are seeing?
CCT, I'm seeing soft tissue opacification of the left maxillary sinus. Also in the pre-maxillary area.
And contrast, even it is there some retromaxillary, also some expanding you can see, right?
Yes, sir.
Then wall of the posterior wall of the maxillary sinus, you can see some erosions.
Yes, sir.
On contrast imaging, what you are seeing?
Contrast imaging, heterogeneously enhancing ultra-synchronicity area is noted.
With the area of the hypo-enhancing area, what is called that hypo-enhancing area? Black mucosa sign or black turbinate sign and all. What is that? Which lesion we will see that?
In mucormycosis.
Okay, fungal sinusitis, right? Okay, so you can see some bony erosion, right? And you are already mentioned there is some standing soft tissue area in the anterior premaxillary and retromaxillary area. You can see some hypo-enhancing area in the turbinate and also in the mucosa. This is called a black turbinate sign or black mucosa sign. This is seen in the fungal sinusitis. Okay.
Okay, sir.
So it's acute fungal sinusitis. We can see the posterior erosion, okay, and the infiltration in the retroangular premaxillary area. And I already mentioned that non-enhancing mucosa, that's called the black turbinate or black. Look for loss of normal enhancement of the sinonasal mucosa. That's what are the complications?
It can have intraorbital or intracranial extension leading to cavernous sinus thrombosis.
Okay, very good. This what you are saying. This is a very common cases we are seeing, right?
I'm seeing enlarged thyroid, and in ultrasound images there is heterogeneous echotexture of the thyroid with increased vascularity, possibly a case of thyroiditis.
Okay, what is that heterogeneity? Can you describe that?
Coarse echotexture.
But you can see some micro nodules, right?
Tiny
micro nodules. Then what are others? What are the other findings you are seeing? Can you see that white fibrous stranding? You can see that, right?
Yes.
So bulky bilateral thyroid gland with micronodularity with a multiple fibrous strand in that, right?
Yes, sir.
So it's a case of
chronic thyroiditis.
Okay. The imaging features early cases there. So how you differentiate it from the Graves' disease? What is the range of PSV is coming in case of Hashimoto thyroiditis? Almost we are seeing what range of PSV? Because
I don't
thyroid toxicosis also there will be increased vascularity, right?
Differentiated on the basis of PSV of the superior thyroid artery.
So thyroid artery, but usually it will come, it's above 40 in case of the Graves' disease. Otherwise, it will be around 15 to 25, 30 and all in case of the Hashimoto thyroiditis. What are the two malignancy can origin from this case?
Lymphocytic.
So this is a case of chronic lymphocytic thyroiditis. So next case. What you are seeing in this case?
The thinning of the extraocular muscles.
Okay, that is not finding. You can see it bone. In paranasal sinus, maxilla, mandible, and all you see.
This osteomas.
Okay, multiple
areas, multiple osteomas, especially in the left maxillary sinus.
Then
and also within the
only in left maxillary only ethmoid. Then below you see that mandible also. And
in mandible also.
So what is your diagnosis? What do you mean by Gardner syndrome with the multiple osteoma? What are the other features will be there in the Gardner syndrome?
Desmoid tumor.
What is the association with any malignancy, TAT malignancy, anything?
Just
FAP, okay, familial adenomatosis polyposis, okay. Other manifestation are desmoid tumor, papillary thyroid carcinoma, high risk for this. So what is this case? Describe the lesion first in the plain CT.
Opacification of the left maxillary sinus, which is noted extending to the left nasal cavity and then posteriorly extending up to the posterior choana.
Okay. So what is your diagnosis? What is that contrast MRI appearance? So you are telling this is epicentered in the maxillary sinus. So why it is not epicentered in the nasal cavity? That is one clue.
Because the medial wall of the maxillary sinus is noted displaced medially with widening of the osteomeatal.
What do you mean by? So you are telling this is a case of, what is your diagnosis?
Inverted papilloma.
Okay. So So how you differentiate it from the AC polyp?
MRI, it is having a typical cerebriform pattern.
Okay. What is the appearance of the AC polyp in case of AC polyp MRI contrast imaging?
It will have peripheral post-contrast enhancement.
Then peripheral mucosal enhancement, right? So
Yes.
what are the CT features of the case? You are seeing some, I marked one side. What is that? Stalk-like hyperostosis. That is the typical features of the inverted papilloma, right? Then you already mentioned about that, this cerebriform pattern in case of the contrast. Okay. So the case newborn with the newborn, what is your diagnosis?
Coloboma of the right orbit.
Very good. Then what is that association? You are seeing anything? One PNS image also I give. Can see anything compared to left side or right side? You see
Small size. Coronal artery.
Okay. So what is your diagnosis? Any association with the heart defect, genitourinary abnormality, growth retardation? So Stark syndrome, what all the finding it will come? Coloboma,
heart disease, esophageal atresia.
Then ear abnormality. Okay. So this is the last case. Patient presented with pain, throat, and all. What you are seeing 3D images.
Elongation of the styloid process, likely Eagle syndrome.
Okay. So Eagle syndrome, thickened and elongated styloid process. What is the presentation will be sharp pain, right?
Okay.
What is the cutoff? That is, we are taking around 3 centimeters at cutoff. Okay. Okay. Thank you. Thank you. You both did very well, right?
Thank you, sir.
Venu sir?
Huh?
No, Venu sir.
Yeah. I think in 50 minutes time now, maximum number of cases were covered. 1 minute.
Yes.
Yeah. Maximum number of cases were covered now. So that too in a classified way, like in parotid space, then carotid space, a carotid space. Okay. Then thyroid. So like that, a set of cases either pertaining to organ or to space. The very good, fantastic presentation of cases. Then one thing, just 2 pages now. We saw one case, retropharyngeal abscess now, retropharyngeal abscess. So suppose somebody asks you whether it is retropharyngeal or this collection can occur somewhere else apart from the retropharyngeal space, any other space is there where you can get collection secondary to infection. Yeah.
Danger space.
Danger space, very good. So danger space and retropharyngeal space now. So whether can we able to separate this danger space infection and retropharyngeal space infection by somehow? Hello.
It extends below the level of
extend. Yeah, extend. So by extend, actually, in what how you can say?
LR space will extend up to the diaphragm, level of diaphragm.
Which one? Danger space.
Danger space.
Yeah.
Yes, sir.
Retropharyngeal space usually up to D3, D4 level maximum, and danger space is up to D3. So if something is extending below the level of D4, then you can say that this is probably in the danger space. Anyway, management wise, actually, it won't make much difference, but still, that shows that actually you know the spaces now, the extent of the space, retropharyngeal, then danger space, and then prevertebral space. Prevertebral space is extending up to prevertebral space.
To say
Along the along the entire length of
whole
the vertebra.
length of vertebral column.
Yeah, that will be reaching right up to the coccyx. Yeah. So beautifully covered now, Dr. Nawab. So the spaces and all. So actually, the localization in head and neck cases, no, the localization of the lesion is actually very important. So once you localize the disease, once you can put the lesion in one compartment, then it will be easy. Then a set of differential diagnosis. Then when looking at the features of the mass, then you can say probably this would be the diagnosis. Okay, thank you very much. Thank you.
Thank you, Dr. Nawab, for a wonderful case session. It was really wonderful, and I think both the residents, Dr. Narmin and Dr. Ari, also did well. I thank them also. Thank you so much.
Thank you, madam.
Dr. Nawab, it was an excellent presentation, discussion, no doubt. I want to add one practical point with respect to the fungal sinusitis. When you see a sinusitis, you have to look for periantral and premaxillary area. The typical we say the invasive fungal sinusitis will have bone erosions and all, but that is a later presentation. So the earliest change will be in the retroantral, periantral, or premaxillary space. So when you see a sinusitis, look for the changes in the fat. So to give a fungal sinusitis, the whole management will differ. So that is one thing I want to add. So I think Dr. Nawab has put a lot of effort in preparing this OSCE-based discussion. It was a very, what you can say, as very systematic kind of approach, case-based. In a short time, he has shown so many cases. And PGs, Dr. IRIA and Dr. Narmin they did very well. They were very specific and very sharp. So thank you, Dr. Narmin and Dr. IRIA. Thank you, Dr. Nawab, for participating and being part of IRIA PG academic session. Thank you once again. So I thank our IRIA State President, Dr. Gomadi ma'am, Academic Chairman Venu sir, State Academic Coordinator Dr. Ramesh Shenoy sir, our Secretary Rijo sir, for making this happen. I also thank the platform MedPiper, JournoMed, for giving us this platform for the presentations. So, and then last, for all the PGs and the faculties who are watching the program, I thank you all once again.